All right, so I'm just going to talk a little about the contemporary management of pilonidal disease. So I think from the setting of being in a general practice environment, this sort of encompasses your younger patients. It may in fact be patients where this is really the only medical problem that they have. And it's a relatively common condition, but has historically and traditionally probably been managed in a way that's not entirely satisfactory. So a lot of the traditional management creates a lot of wound morbidity and frustration for patients. And some of that then flows onto general practice because these patients are often sent there with chronic wound problems, often after having surgery for this condition. But there's more recently been quite a lot of described techniques that are effective and don't involve wound morbidity to any particular extent. And in particular, more recently, endoscopic treatment, if this has been described. So I just wanted to go over the condition a bit and then cover some of the traditional treatments and the pitfalls and problems associated with those, and then go on and highlight some of the more contemporary management strategies and how I think they're helpful and probably more beneficial to patients. So these photographs on this slide are actually of treating the condition endoscopically. This is an endoscope that's used to treat pilonidal disease, and these are actually images, endoscopic images inside a pilonidal sinus being treated. But if we go back historically, this condition was described in 1833 as a cyst under the coccyx, and it was subsequently appreciated that this pathology contained hair, and so it was subsequently described as a pilonidal condition from the Latin for nest of hair, and was initially not thought to be an acquired condition. It was initially thought to be an embryological condition, and that there was some sort of congenital remnant structure that contained these hairs, and the basis of the condition's treatment was then to sort of remove that embryological remnant, because at the time that was the understanding of the pathophysiology, which is not correct as we understand it now. And it became really a fairly important condition in the Second World War, because there was actually a high incidence of the condition among individuals serving in the military. And in North America, it became known as the Jeep Rider's Bottom or Jeep Rider's disease, because military personnel who spent extended periods of time riding in military vehicles with sort of fairly rigid suspension and out in the heat and exposure, a lot of them got this condition, and it caused a lot of morbidity from the military's perspective, because over that period in the Second World War, there were about 80,000 military personnel who had to be admitted into US Army facilities. And highlighting the problems with traditional treatment of this condition, these patients had pretty protracted hospital stays, averaging 55 days, and obviously leading to a lot of people being sort of out of action. And that really led to the condition being considered more important and more emphasis being placed on sort of improved treatment. The origin of that really came from the fact that the condition had a disruptive effect on the military service during that period. So here you see the typical Jeeps of the time. And pilonidal disease is really a spectrum of conditions. And some patients who have this don't really have any symptoms, but do have these cystic or sinus-like structures deep to the sacral skin that contain hair. And then that can lead to abscess, sinus, fistula formation. And the typical clinical picture is that you'll see pits overlying the sacrococcygeal region. And these may or may not be infected. They're typically in the midline. And then there'll be a fibrous tract lined by granulation tissue deep to that. And there'll be hair contained within the lumen of these tracts. And this is where the name pilonidal comes from, is that it means a nest of hair. And a typical patient who gets this condition is a young patient. It's generally a condition that doesn't then perpetuate into later life if you've had it in your younger life. It seems to burn out which is important to tell patients that they won't actually have this forever. But typically, if you're going to get this, it will start in the late teens or early 20s. There's a progressive decline in the incidence towards the end of your third decade of life. And it's more common in particular individuals. It's more commonly described in hirsute individuals and people who've got particular hair morphology, where the hair is dark, and it's not the color of the hair that's important, but the darker hair is typically stiffer. And there's often an association with sweating, moisture, an occupational association with sedentary and type activity or activity where there's sort of friction on the bottom area, such as driving a lot. So like driving a truck or driving a taxi or a bus. It is described on other parts of the body in other occupations. You can get it in the web spaces of the fingers, which is typically described in barbers and hairdressers. It's also described in other parts of the body in people who keep sheep or birds. And there may be an association with the natal cleft morphology. So if you have the sort of a deep, narrow natal cleft, there's an association with obesity, there's an association with family history, and there's some association with personal hygiene in some cases. Essentially, if patients present clinically with this, they'll have one of three clinical entities. They'll either have an abscess or they'll have chronic disease where there are pits that are producing some degree of symptomatology, be that pain, discomfort, discharge, itching, or they'll have so-called complex or recurrent disease where they'll have had treatment for the above two conditions in the past and the condition's been refractory to that, or there's been recurrence. And that would represent about 30% of the overall cohort of patients. And the best treatment depends on what clinical entity you present with, but it also depends on to what extent the symptoms are, how severe they are, how debilitating they are. There are going to be cases where the best thing to do is not to do anything. And other cases where different surgical approaches may be indicated. If you see a patient with this, even if they have an abscess, usually they won't be constitutionally unwell from that. So they'll typically not be toxic, not be febrile. And there are exceptions to that, but that's not characteristic. And then you'll typically see pits or sinus tract in the sacrococcygeal region. And if there's an associated abscess, they'll have the typical clinical features of that: redness, warmth, tenderness, fluctuance, and possibly surrounding induration. So in the primary care setting, if there's soft tissue pathology in that area, there may be other conditions that could be, such as anal fistula, such as a fissure, which would more typically present with severe pain, defecatory pain, minor bleeding, and probably inability to perform an adequate rectal examination because of pain limitation. Hidradenitis can present in this area, although typically the patient will have hidradenitis on other parts of the body and a history of that. Perirectal or ischiorectal abscess can present in this way, but usually closer to the anal area, and also more typically not directly over the sacrococcygeal region. Syphilis and tuberculosis are conditions that can mimic this in some patient cohorts. It's not particularly common in the typical Australian population, but it would need to be considered in some subgroups, depending on their medical history, ethnicity, whether they come from a country where those conditions are more common. And then osteomyelitis of the coccyx, this would typically be in the setting of ulceration or tissue loss over that area, which is more commonly seen in decubitus ulcers, which would not be typical in this age group in an otherwise medically well patient. But they're the sorts of other pathologies that can manifest in that area anatomically. And this is a review paper that was published in the Techniques in Coloproctology that looked at traditional treatment and was published 2 years ago, entitled The Evidence Base for Pilonidal Sinus Surgeries, the PITS, essentially being fairly critical of the traditional treatments for this condition, both from the perspective that they lack robust scientific evidence to support their approach, but also from the perspective that they tend to produce a lot of morbidity, arguably in a lot of cases more morbidity than the condition produces. And I'll just quote the last sort of sentence or paragraph in the paper where the authors say, ask yourself if you would want to have a large hole cut in your natal cleft, left to heal by secondary intention over months. If this is not suitable for you, then this is not suitable for your patients. And I strongly agree with their sentiment. And really that sort of underpins a lot of my practice in this area, that statement. And so if you think about that clinically, if you saw a patient in the rooms who perhaps presented with symptoms, which overall might be relatively minor symptoms like this, and they might say, well, intermittently this gets a bit red, I intermittently get some discharge, that discharge is questionably at times infected, this is uncomfortable, sometimes when I sit down this is a bit sore, and you send them off to get a specialist opinion, and then they have an operation, and then the outcome is something like this, where they've essentially had all the disease excised and been advised that that needs to heal up by secondary intention, same as this, or by vacuum dressing therapy, then quite rightly people might question whether in fact the treatment is actually worse than the condition. And that's a pretty reasonable comment. Similarly, if they have an abscess drained in the area, then a lot of the traditional management is to then pack the abscess cavity, which is effective, but it takes a lot of time often to get the thing to heal up. And it consumes a lot of healthcare resources as well. It often requires sort of daily dressings, and there's often some nursing service that is providing daily care to these patients for an extended period of time. So there are sort of contemporary ways of dealing with this that are probably better. And why are they better? Because the traditional treatments tend to result in significant wound morbidity. And in fact, even in those examples I showed you, if the wounds are closed by some sort of closure technique, there'll still be a not insignificant rate of wound breakdown and wound complication in those sorts of cases. And that will mean that the patient will then have to go through sort of prolonged wound care to achieve healing. And it's important to remember with all these treatments where there's a lot of wound morbidity and potentially scarring and so on, that this is a condition that tends to affect people in their late teens and early 20s who are otherwise usually medically well. This is the population of patients in the community that have, where body image is the most important, and where they're at the sort of stage in their life where they're forming relationships and where attendance at study and work is really crucial to sort of progression in life in the years ahead. And so having that sort of process interrupted by or sort of having chronic wound care is quite significant often in these cohorts of patients. So in terms of contemporary and minimally invasive approaches, so this is the endoscopic approach. So what we see here in these photographs is that the patient's probably got a similar clinical presentation to the one I showed you in a few slides ago. And then one of the openings is enlarged. There's different ways of doing that, but in this case, it's being done just with a skin punch biopsy forceps. So you make an opening that's about 4 millimeters in size. And then through that, you can then introduce a special endoscope into the underlying pilonidal sinus. And so in pictures D and E, this is what you see. So you basically see these sinus tracts lined by hair. And then there are instruments that can be passed down the endoscope that allow you to, under vision on a television screen, on a video monitor, basically do what you would be doing through an open operation with a big incision, which is debriding the tract, removing the hair and de-epithelializing it. But at the end of all of that, the only wound morbidity is a 4 millimeter punch out of one of the pits. And so the amount of healing the patient has to do post-procedurally is pretty minimal. This is a similar technique, but not using an endoscopic approach. So this is the GIPS procedure, which was described relatively recently by an Israeli surgeon. And so the principle is similar, whereby all the pits are opened up, and there's different techniques for doing that. You can use a punch biopsy forceps, or you can excise them. But essentially all the skin between the pits is preserved, and then any debridement is done without removing the intervening bridges of skin, which again means that the wound you have at the end of the procedure is not extensive, and will over about a 4-week period heal up. As Gibbs described it, there's a debridement done, and then this is all just left in the debrided state. I generally then inject this area with this stuff, which is Tisiel, which is a sort of biological glue that contains thrombin and fibrinogen. So I tend to then fill the underlying space up with that, and then put a negative pressure dressing on the skin itself. But just doing what he described and preserving this skin makes a pretty big difference to the overall morbidity of the procedure for patients. I've got a couple of videos that colleagues have put together. One has been put together by Gibbs, and the other one by a surgeon colleague, just to show you. So this is the endoscopic approach. So I'll just scrub through a bit. So you see this is the typical pilonidal, and then this is an example of a pilonidal abscess.
Oh, sorry, Ken.
Yeah.
Where we can't actually see the video, we're still on your slide
Okay.
for some reason. Might have to change to a different screen.
Sure. Okay. So where do I do that? So I've got share screen here. Sophie, whereabouts do I need to?
We're still on your screen on the presentation. What I can do is possibly share my screen, perhaps.
All right, I just need to know where to go in the Zoom to change the screen sharing. So
maybe if
new share. Oh yeah, new share. Okay. So is that better?
Yeah, that's the one. Yep.
Okay. So all right, I'll just go back then. So then these are typical examples of pilonidal disease. It's an example of a pilonidal abscess. That's where an abscess is previously discharged. So this is like a traditional approach of opening the wound. If you treat this endoscopically, you position the patient and then remove the hair. But then in theatre, I'll just let this run through a bit now. So you're just initially opening up the main tract and doing some limited debridement under direct vision. But then subsequently, you can introduce the endoscope once this has been done. So this is the endoscope. And there is like a special endoscope that's specifically designed for this, but it can be done in a hospital that doesn't have access to that equipment. It's very similar to a cystoscope, a rigid cystoscope. So you can in fact use a pediatric cystoscope. So this is an endoscope in the pilonidal sinus tract, and then you can see hair in there. That's what those those dark lines are hair, and then you can see there's fluid filling up the space. And then essentially you can pass the instruments down through it and use them to remove the hair under direct vision. So the reason that these don't heal or that they stay as chronic wounds is because you've got certain factors that prevent wound healing. And those factors are infection, the presence of foreign material, and epithelialization. So to get the wound to heal, you need to just remove those three elements: infection, foreign material, and epithelialization. So traditionally that's been done by widely excising and debriding the tissue, which does achieve those aims, but then the body has to heal a big wound. If you use a technique like this, then you can remove all the hair, de-epithelialize the tract, and clean out all the infection without creating that wound. And so then post-operatively, the patient doesn't have to do a lot of healing in comparison to the traditional technique. So this, they're just showing now that you can pass this thing down that's kind of like a medical grade eyelash curler, and you just basically twizzle it around in the tract, and then it picks all the hair up. And then once that's been done, this is an electrode that's passed down the tract, which is a similar electrode to what's used in urology to do cautery in the bladder. And that then allows the epithelium to be removed, to de-epithelialize the tract. And that should then create healthy tissue that's free of infection and foreign material, which then will allow healing to take place. So I'll just, so that appearance is the appearance of the tract after it's been coagulated. And then it's pretty typical at the end of that to put a negative pressure dressing directly on the skin. So that's endoscopic treatment. And then this is sort of minimally invasive, non-endoscopic treatment. This is a GIPS procedure being done by GIPS, where you just core out the pits, but preserve the skin. And then having done that, do the same debridement and clean out process that was being done with the endoscope through one of the pits. But you preserve all the skin bridges in between. So you only really remove the skin that's directly affected by the disease process, and you don't aim to remove any skin or soft tissue that's uninvolved. The same principle that you're removing all the infection, all the foreign material, de-epithelializing it, but creating a smaller wound, so the patient has to do less healing post-operatively. And that's after 2.5 weeks. That's just a further example in a different patient. The data shows that if you, for example, use endoscopic treatment, after one treatment, about 70% of patients will have a clinically satisfactory outcome. And then if you repeat the endoscopic treatment, that bumps that up to about 91%. But there'll still be a group of patients who will not have a satisfactory outcome. And so they will need a potentially non-minimally invasive procedure. So then the question is, which of those procedures should they have? There's lots of published literature on this. The published literature suggests that the patients that have the best outcome, if they have a large wound made, are those that have a flap-based reconstruction of the wound, and that the flap that has had the best outcomes with the lowest rate of flap complications for this particular condition is the rhomboid or Limburg flap, which is basically constructed the way I've depicted in those images. And so you then interpose the flap like this, resulting in a scar that looks like this. And there's a specific way of doing that. And the described technique that's got the best outcome data is this technique, which is this protractor-free flap, which is based on the idea that the excised tissue that you excise is in a true rhomboid. And to make a true rhomboid, you need to mark out the craniocaudal extent of the disease. And then if you measure that distance and call that X, you then need to make a line that bisects X halfway along that is 0.6 of X, which is based on this trigonometry. And that then gives you a true rhomboid. And then the flap, the projection of the flap is a true rhomboid as well. So you project the distance from there to there in this direction and in this direction. And then that line there gives you your flap at the correct angle. But that technique's been validated in reasonably large patient cohorts. This was published some time ago in the DCR by a group in the UK, but one of the authors of that works in Sydney now. And in 120 patients, no patient had a major flap complication and 6 had minor flap complications. So, a minor flap complication would be, for example, this corner not healing as well as the rest of the flap and needing some dressings for a few weeks just in that one area. That would be an example of a minor flap complication. But essentially, in none of the patients did the flaps essentially become non-viable or need to be widely excised or taken back to surgery or anything like that. So there's a few newer technologies that you can use when you're doing these procedures that I think are pretty helpful. I'm not sure how familiar people are with this suture technology, but these are what are called barbed sutures. So these are sutures that you don't tie knots in. There's 2 on the market in Australia. There's a V-lock type suture and Stratafix suture. The main difference is in the profile of the barbs. But essentially these sutures, the barbs hold the sutures in place in the tissue. So you don't have to tie any knots, and they're very good. They're very good in lots of situations, but with respect to pilonidal surgery, because the flap is done in such a way that there's a lot of fatty tissue between the skin and the base of the flap, these sutures allow all the fat to be reapproximated. And when you do that, it takes all the tension off the flap. Because there are no knots, you don't get any fat necrosis, which then significantly reduces the risk of infection. You can also get these sutures impregnated now with antimicrobial material, and that's been validated in a number of settings to reduce surgical site infection complications. It's actually recommended by the National Institute of Clinical Excellence in the UK as something to do routinely, but it's not done routinely in Australia, but it is quite helpful. The other technology I sometimes use with these flaps is I use this. I put this in the base of the flap. This is used in theatre to stop bleeding. But it's basically a matrix of gelatin granules that are impregnated with thrombin. And so you can basically put that in the base of the wound before you put the flap in. And that then will help to reduce bleeding and hematoma without you necessarily having to use a lot of cautery, which I think then tends to sort of cause some tissue damage. And it's not so good if you're doing a flap. The only other thing I want to say is that you can use these endoscopic treatments to treat abscesses. That hasn't been validated in as large a group of patients, but that's quite a good technique. So you basically do similar to what I showed you in the endoscopic video. If the patient comes in with an abscess, you just make a very small cut, like 3 or 4 millimeter cut, and then you put the endoscope into the abscess cavity and use it to wash the abscess cavity out. There's a similar kind of concept to the concept that's used to wash out infected joints, actually, because they're normally washed out with an arthroscope. But what that allows you to do is get a very high volume of lavage fluid through the infected area, clean it out really well, but open it up really minimally. And if like in pilonidal disease, flush out any hair. And the initial studies suggest that if you do that, the patient's got a lower risk of going on to actually get secondary pilonidal disease and need to have any kind of secondary surgery. The other thing that's quite good about it is the patient then doesn't need to go home with any sort of nursing care or complex wound care. We usually just give them a syringe and just get them to irrigate through the small hole in the shower once a day before we see them in the clinic. So that's quite good and avoids quite a lot of morbidity. That's pretty much the only main things I wanted to cover. I was hoping to use the rest of the time to address any questions people might have.
Thanks so much, Ken. We do have some questions.
Yeah.
So we've got the first question we have is, what is the recurrence rate compared to traditional surgery?
Yeah, sure. So with the endoscopic surgery, patients will generally need one treatment 70% of the time. If you look at the papers that cover traditional surgery, it's probably using recurrence rate as a marker of the success of the operation is probably not the most appropriate marker to use, because, like, if I just go back a few slides, if you do that or that and say that you've got a low recurrence rate, you have to balance that up against the morbidity of what you've done to achieve that. But the chance of needing further treatment if you have an endoscopic treatment is about 30%. And if you have the treatment twice, then about 91, 92% of patients overall won't need any further treatment. Yeah.
Great. The second question is it important to get the patient to have X-ray, so an X-ray of their coccyx when GPs first see them?
No, I don't think so. So I think the question might have come up because I mentioned about osteomyelitis in the differentials, but no, I think in the majority of cases it's a clinical diagnosis. If the patient's got local symptoms and when you examine them, they've got either like features of an abscess or features of pits, that's sufficient. And in the specialist setting, I wouldn't typically do any further imaging either. The setting where I do sometimes get imaging is occasionally you'll get referred a patient where there's a pit relatively close to the anus, and it's a bit unclear whether that is pilonidal disease or whether it's a fistula. And then the patient may also have bowel symptoms, and then you're not sure if it's a fistula, whether it could in fact be in the setting of having undiagnosed inflammatory bowel disease. In that setting, I would do an MRI, which I would organise, but I don't have to do that very often. That's probably really the only time I typically arrange imaging in working these patients up. In the predominance of patients, the assessment and diagnosis would be made clinically. I wouldn't typically do any plain films, no.
Okay, thanks, Ken. We've just got a few more questions. From David, are you suggesting GPs might upskill to undertake this endoscopic procedure with a simple abscess?
No, I'm saying that if the patient's got an abscess and you treat it endoscopically, I think treating it endoscopically needs to be done in an operating theatre in a hospital setting. But what I'm suggesting is that if the patient comes to hospital and has the abscess treated in that way, then post-procedurally, they need minimal further care. And there's emerging data that the probability that they'll then go on to progress and have a chronic problem with pilonidal disease that needs secondary intervention is reduced. The idea that you could do that in the GP setting is limited by like a lot of things. But one very clear limitation is that the sort of equipment you need to do that is costly and would only really be available in a hospital setting, in a theatre environment. So no. I guess the question might be coming from the idea that if you just drain the abscess in the rooms, you can do that. But if you drain a pilonidal abscess in the rooms, it's pretty unlikely. You'll relieve the patient's symptoms and they'll feel a lot better. but it's very unlikely you'll remove all the hair. And if you don't do that, it's very likely they'll get some secondary representation of something that will need something done at a point in time. Whereas if you do this, you can do this as one primary procedure, and then hopefully that won't require anything further.
All right. Okay. So just to confirm, this type of surgery is not suitable for a GP practice.
Correct. Yeah.
Final question from Shemnika. Could you please comment on cetons and the plan of management with them?
Yeah, sure. So I don't use those in pilonidal disease, but I think what the person who's asked the question is making reference to, some people will make 2 small wounds and then connect those wounds with a rubber suture, which is called a ceton, and use those to manage pilonidal disease. I don't really see much role for that in pilonidal disease myself. They're used in fistulas, and they've got a clear role in fistula management. But I think in pilonidal management, basically the patients have either an abscess or a network of sinuses that contain hair, infected material, and are epithelialized. So if you want that problem to go away, you need to remove the infection, the epithelium, and the hair. If you've done that at the end of your operation, then you don't need a ceton. And if you haven't, and you put a ceton in to control infection, then if you've still got epithelialization and trapped hair, eventually the problem's going to recur. So it's not something I typically do for pilonidal disease, although there are people who do it.
Okay, great. Thanks, Ken. I think that's all the questions that we have from the audience. Did you have any other comments you wanted to make before we wrap up?
Oh, not really, other than to say that I think this is a condition that a lot of the time in the past has been treated as a sort of a simple problem. But in actual fact, a lot of these patients have a lot of problems from the time of diagnosis, and have often had a lot of treatment, and often had quite a lot of morbidity inflicted upon them from the treatments they've received. And it does require sort of a fairly considered approach to try to get these patients to be free of symptoms and to really have a good quality of life. And it's also pretty important to remember that because it's a condition that burns itself out, if you do a pretty major procedure on it and then that procedure ends up causing morbidity, then they may be left with that morbidity down the track, when that could probably potentially have been avoided. They're probably the main comments I'd make.